Hi, it's Dr. Centeno, and thanks so much for joining us today. Got some interesting things we're going to go over. I've been involved in, obviously, the creation of the PICL procedure, the EPICL procedure in treating craniocervical instability. And through the years, I've also done a lot of research on all of that. I've just put out that informally, and then we've been working on a larger registry data set to publish in a peer-reviewed publication. And then I've shared lots of different data sets with patients, including the As Seen case series that I've been doing recently. So today we're going to get into all of that. What's the status of that peer-reviewed publication? What's the status of the data analysis? What have we learned about the PICL procedure, the EPICL procedure? Where might that take us next, etc. So as usual, I'll do a small presentation here up front, and then we'll go to Q&A. If you're interested in asking a question, just put it in the comments where you are, either YouTube or Facebook. And then I'll put your question on the screen later and try to answer that question. That could be a question about what we're discussing today. That could be a question about anything at all. It doesn't have to be what this topic is today. So for those of us just joining, we're going to talk about the PICL, EPICL research update. It's probably one of the more common questions I get. What's going on with the research? What kind of research have you done so far? What are the results of this procedure, etc. So we're going to dive into that today. Again, I'll start with a didactic portion. I've got some slides to share, and then I'll go in the direction of answering questions about this topic or really anything else. So let's get started on the presentation here. So first question is obvious, right? Why is nobody else really doing any research on CCI treatment outcomes? And that's a good question, right? There are a few different providers claiming to treat CCI out there. On the injection-based side, we've got a number of different surgeons. The only surgeon I know that's done any meaningful research to date on CCI in particular is Dr. Henderson. The rest seem to have not done it or have done it more on different patient populations. On the non-surgical side, I don't know anyone else that's published a darn thing. So we seem to be the only group that's putting out any information like this. So why isn't that happening? Well, it's super expensive, right? I've got a team of four that's currently working on the data analysis. And those aren't cheap people. One's a doctor, one of our fellows. One is a PhD research scientist who runs our clinical research at the office in Regenix. Another one is a master's level provider. And the fourth one is a PhD. So it's expensive, right? You also have to have infrastructure. And if you're a doctor, it takes hundreds of hours away from revenue generating activities. And so that's super expensive. It's not just expensive in employing all those people, but as the doctor, you have to get involved in this at a substantial level, or the research team isn't really going to know what it is they're looking at. And that's always the issue with clinical research, because the doctor, especially in this kind of specialized area, really needs to be involved. So what's the status of the peer-reviewed publication? We've been going back and forth on the analysis of the registry data that we have. For example, I just expanded the treatment dates that we're including to try to increase the total number of patients in the study. We're trying to fill holes in the registry data, and I'll bring that up a little later because we could really use your help there in filling those holes. And I've been using the smaller As Seen case series to probe hypotheses, some of which I'll go over with you today. So what is CCI registry data? Well, we use a registry or a treatment registry to collect data for this procedure. So that means that we collect pre-treatment data on all consented CCI, PICL, and EPICL patients. Those are those questionnaires that you have to fill out before your procedure. And those include things like the headache inventory, SF-36, SANE, single assessment numeric evaluation, which is more after the procedure, neck disability index or NDI, and numeric pain scales or scores. And those questionnaires are sent out automatically at 3 months, 6 months, and annually. So that's the registry data. Now, we're going to go into some new analyses on the as-seen case series data today, because that's what I've been using to probe some of these research questions and try to see what might the trends be. What do we want to take the time and effort to do with a larger data set? So just to define that data set, this represents all treated patients seen in the office who had a procedure and an outcome from a prior PICL procedure. It's basically structured / unstructured. Some of it's structured, like I'm collecting percentage improvements or SANE scores or the type of CCI. Some of it's unstructured and collecting symptoms, etc. And then there's some unstructured information in there that's specific to the patient, i.e. someone who is bedbound can now walk 7,000 steps, etc. And it doesn't represent patients who decided that they either didn't get enough relief after number 1 to warrant a return to my office, or they did get a relief, and they got lots of it, no real reason to return, or for whatever reason, they couldn't continue care beyond the first procedure. So one of the things I did for this analysis was to go through and update a little bit more than the first half of the treated patients on that as-seen case series. As I was collecting that data early on, it sort of had a different purpose, I thought, than as I went. So I had to go back and look at everyone's CCI questionnaires, update the data in here, make sure all of it was accurate so I could harmonize the whole data set so I could take another look at this data. So this is the frequency of CCI types we're talking about in that data set. Most of them are 2B. Then we've got 3B, which is C2-3. So again, 2B is the C1, C2 side-to-side instability. 3B is C2-3 instability, where the C2 goes backwards on the C3 in extension. 2A is where the ADI opens in flexion, so that's a transverse ligament issue. 3A is where C2 goes forward on C3 in flexion. 1C is the skull sliding type, and 1A is the low clivo-axial angle type. So those are the types that are considered in this data set. And then this is the cleaned up symptom list. I went through the symptoms that were reported, tried to harmonize them, get them all into a little bit more structured format. So as you can see here, we're still rocking headache and neck pain as the top 2 issues. Dizziness and vertigo is big. Brain fog is big. Fatigue is big. Jaw/TMJ pain is big. So those are the real biggest ones that we have in this data set. This is the percent improvement grouping from that data set. So 10 cases in the 0 to 25% improvement, 12 cases in that 25 to 50, 31 cases in that 50 to 75, and 7 cases in that 75 to 100% improvement range. So let's get into this one. For this one, I was looking at using statistical methods to try to see if there's any improvement differences by CCI type. And, kind of what I ended up on after looking at all the different types is that there could be a difference with 1C, which is the skull sliding type, and meaning that might map on to patients that do better. And this is what the distribution of the data looks like. You can see there seems to be a difference in the mean here. with some differences outside the error bars. But the problem is there's not a lot of patients here with 1C. There's a lot more patients without 1C. And so this is one of those things where we could also be getting a false signal because only some patients with flexion extension upright MRIs have a 1C measurement, meaning 1C isn't something we can generally get off a digital motion X-ray or DMX. So we generally have to take it off of an upright flexion extension MRI. Now, how about if we compare two very different types of CCI? A 1A is, again, that low clivo-axial angle type where the head's rotated forward and the dens goes backwards, versus a 2B, which is side to side at C1, C2. And this analysis, classical statistics didn't really show that much, had to get into Bayesian statistics, and eventually the Bayesian statistics said there was a direction that was consistent with lower outcomes for the 1A. But again, we have fewer 1As in there because it's mostly a measurement that comes off of upright MRIs, and not all the patients have upright MRIs. How about an outcome by the cause of CCI? So we had hypermobile patients, trauma patients, and patients where the cause was unknown. So if we look at that, there really isn't a difference here in any of the statistics between hypermobile and trauma patients. And that's always been our biggest question. That's a question I've answered previously in an earlier data analysis. And I think that continues to hold up as we look at it, that hypermobile patients don't do any worse or better than patients that have this with normal ligaments and get it because of trauma. How about headaches versus no headache in outcome? So here we've got little bigger ends to compare, and there really isn't a difference between headache versus no headache. How about dizzy versus not dizzy? Here, again, not really a difference between dizzy versus not dizzy and how they respond. So then I did this rather complex analysis where we really try to look at, is there any CCI type, cause, or symptom combo that rises to the top based on improvement? And ultimately, the answer was that when you ran these different combos, really any true differences in all of these different groupings between different cause, different type, and different symptoms, the differences are small between those groups. So where is all of this headed? Hopefully we can put the published paper based on registry data to bed sometime in August, probably towards the end of August, early September, I'm thinking. Probably take the whole month of September to get a completed draft. Half of the paper, as I think I've said before, is already written. It's really just plugging in the data and describing the data that the story that the data tells. And then after that, it usually takes about 3 to 6 months on average, sometimes shorter, sometimes longer, to get something published once it's submitted, because it has to go through that whole peer review process. So how can you help? One of the things I do want you to do is we do have to fill in a few more data holes here, or at least I'd like to. And what's a data hole? What that means is that in the registry, someone just failed to respond. So let's say we only have their 3-month response, but we don't have their 6-month or 1-year response. So I'd like to get and fill in some of those. So our folks are going to be calling various treated PICL patients to try to get them and prompt them to fill out those forms. So really, if you want this data to be published and analyzed in a larger way, one of the things that you can really do to help is to spend some time just putting posts on social media. Hey, if Centeno's office reaches out to you to get more data because you've had a PICL procedure and for whatever reason you weren't able to fill out those questionnaires they send to you, please respond, because that's going to make sure that all this stuff gets published and it's as robust as it possibly can be. So in summary, there still really isn't any noticeable outcome difference between hypermobile and normal ligament patients. That seems to be one that's holding up pretty well. The cause of CCI doesn't seem to matter. And CCI type 1C could do could do better, but we're going to have to look at that more in the registry data where we have more of those cases to make a go of it. And CCI type 1A cases could do slightly worse than 2B. But again, we need more data. So that's something we're going to run on a larger data set. And having a headache or not, or being dizzy or not, doesn't really seem to impact outcome. Okay, let's take some questions here. Let me pull that out. Okay, so questions. Cassian, in your PICL research, do you include data from your proteges that don't practice with you now? Not sure about what that means. Proteges that don't practice with you now. So I don't know what that means. I think you may be talking about fellowship or fellows, but none of our fellows have ever been permitted to do the PICL procedure. So they wouldn't be involved even on a training basis with the PICL procedure. They're not allowed to perform the PICL procedure. So that, that one doesn't really make sense. Anja, does the existence of bilateral complete ponticulus basically increased chance of arterial dissection, A or nuca? So what Anja is talking about here is that there's a little bony arch that can go over the vertebral artery. The theory would be that if you got a chiropractic adjustment and you had that little bony arch over usually C1, and that the vertebral artery snakes through it, that could increase the risk for vertebral artery dissection with a chiropractic adjustment. I don't think we know that, or at least not that I have seen based on the existing research. So not quite sure how to answer that one. I don't see a difference in what I have noted through the years, but I also haven't done an extensive research review on that topic. Lynn, I have traumatic cervical misalignment along with teeth and jaw misalignment. Planning to see upper cervical care with Blair and knee chest care. Would it be available to do it? Not quite sure what that question means. I think what you're asking is, can Blair Chiropractic help upper neck issues? I think it can. Raj, hi doctor, can you speak about trigeminal neuralgia, symptoms and causes, including CCI? Yeah, Raj, I've got a lot on my YouTube channel on trigeminal neuralgia, but basically in craniocervical instability, we see that the trigeminal nerve in some patients can get irritated. Normally the trigeminal nerve issues or trigeminal neuralgia goes away once the instability is treated. Now, there are times that we have to directly treat the trigeminal nerve, and that can also be done. And there's also a large group of patients who believe they have trigeminal neuralgia, but really don't. They basically just have pain in this area that's coming from their TMJ or muscles. So realize that that's another big patient population that we see. Hey, do me a favor, give me a like, share, subscribe right now, because we got to get those likes up for this one here. If you want to pay it forward to other patients, like this where you are, or subscribe to the channel, because at the end of the day, that helps get this type of information out to patients. And if you found this Q&A session, obviously you want to make sure that others that have problems can find it too. Lynn, having traumatic cervical jaw, I think I got that one already. Cassian, when you treat nerves with LPPRP, looks at poor PRP, how do you identify the specific target portions of the nerve and trap points? What else? Yeah, so we tend to treat nerves a lot with platelet lysate, more so than leukocyte poor PRP, but you can do both. You generally look for an area where the nerve could be getting compressed or might be scarred down or might be getting trauma. And that's the area that you treat. It's under ultrasound guidance. So you literally inject the fluid that you're injecting, and let's say that's platelet lysate, around the nerve, and that kind of peels away the structures or scar tissue from the nerve. It also provides growth factors on the ground. One, is it CCI that has delayed exercise-induced deterioration? I don't mean like a sprained wrist, but I mean completely exhausted from headaches, muscle aches, and depleted of energy the day after exercise. I think what you're asking is, does CCI have as a common symptom exercise intolerance or exercise-induced fatigue? Yes and no. We see a lot of fatigue in CCI patients. Most of it is due to probably incomplete sleep due to the symptoms of CCI. And that symptom tends to go away in general as we treat the CCI. Now, specifically, do CCI patients get exercise-induced fatigue? It depends on how strict that definition is. Most of our CCI patients are exercise intolerant. But if you looked at the strict definition of I exercised, therefore I can't function for the rest of the day, CCI patients would be in that category when it came to increasing their symptoms. But if the only symptom is fatigue, they generally wouldn't be in that category. Raj, can someone develop CCI due to age, wear or tear? It's always a trauma that triggers it. You know, Raj, there are probably patients out there that have small amounts of CCI due to age and wear and tear. The vast majority of patients we see get it due to trauma or hypermobility. And then there probably are patients out there like that. More commonly, we see, for instance, scoliosis patients who have kind of a fixed rotation at C1, C2, develop CCI due to that additional wear and tear. As to whether or not working on a computer can cause it, it's theoretically possible, but I would say less likely to get it from that mechanism. That's going to be more commonly craniocervical syndrome, where the upper cervical spine is getting irritated and that's causing symptoms. Submitted advanced by Harry Winston. Are there specific supplements that you would recommend or should be avoided for CCI patients? I would recommend that stem cell support formula, fish oil, or omega-3s like EPA are usually good supplements for this kind of problem. Lynn, if CCI is the root cause of my body compensation, will teeth and jaw alignment correct automatically, or how can I manage my whole body compensatory changes? Well, Lynn, CCI does cause proprioceptive difficulties. So what that means is that position sense information comes in from the upper neck. When that position sense information is abnormal, it can change how the body moves or positions itself. And so normally then if you fix the CCI, you fix those little things in the body. So for example, your brain might believe that a tilted head, is normal. And then you're going to use the righting reflex to go like that to try to bring your visual field horizontal. And as you can see, that can contort your body. Josh, Chris, Dr. Centeno, do you think no one doing research because most physicians who could evaluate, treat, or do research don't recognize CCI syndrome associated anatomy and pathology? I talked to a radiologist, MSK radiologist around my area, and that read from my hospital from around the country. None of them recognize CCI, even know what the Montreal Bridge is. Humbly didn't know about CCI until Centeno-Schultz Clinic started researching and treating. They don't teach CCI. Yeah, I mean, that's part of it, Josh. I think what you're talking about is a lot of research is done in university settings. But as you know, regenerative medicine research isn't done in university settings. You know, we're still in the world where most regenerative medicine research is done outside of university settings. But I think that certainly has an impact. Yes, I think what we see there is a lot of just a lot of lack of knowledge of CCI as a potential issue. And it's not just CCI. I mean, even cervical instability, right? What you and I would call subfailure cervical instability, maybe 3 or 4 millimeters of translation, even lower down the cervical spine, causing symptoms. Whereas the average surgeon isn't probably going to fuse that. They would recognize it if maybe was larger, and they'd want to fuse it. So there's a lot of different things at play here. One of them is that university dichotomy of universities doing more research. But a lot of it, I think, also is just providers don't focus on research because it's expensive. I designed my practice from the ground up many, many, many decades ago to accommodate research. I put things into place to allow that to happen and to afford to do it. But at the end of the day, I have to be honest with you. If I had not done any research at all in my practice, I'd probably be millions of dollars richer right now. Meaning at the end of the day, we have spent millions of dollars on research that could have gone into buying new fancy cars and all sorts of stuff. But the research was always more important. Ezra, your recent interview with Dr. Henderson was amazing. You're planning to do further collaboration with him in the near future. You can share with us. Yeah, so Ezra, once we get this paper to the point of the writing phase, meaning first draft, second draft, third draft, we're going to send that to Dr. Henderson. He wants to be involved in that writing, and he wants to be involved in the paper. So yes, we're definitely going to do more with Dr. Henderson. Again, he's the only guy I see out there who's in CCI who's spending the time, energy, and money to do research. So that's amazing. Marcia, our patients who have had CCI or TC surgery in the data set. No, we don't have anyone in the data set. That's an exclusion criteria for the larger paper, having had prior surgery. For the data set that I showed you, the As Seen case series, I don't believe there's anybody in there who has had any type of prior surgery. There may be 1 or 2 decompression patients, but for the paper, it's going to be an exclusion. Hallie, does the cadence in which you get a PICL bear any consequence in the efficacy of treatment? I know you recommend most people get 3 or 4 months in between, but does the time in between have any bearing on how well stem cells react with each treatment to work? For example, having the first 2 spaced out every 6 months, third at 3 or 4 months. Secondarily, how does a year or 2 after the third or fourth? Yeah, Hallie, best I can say there is that we did a natural experiment way back when in the COVID times. We had patients who were willing to come back on their specific cadence every couple months, maybe 4 to 6 months. We had patients that didn't want to come back or couldn't come back or whatever. And so we really saw, I think, in that period, about half the patients who delayed tended to go backwards, and about half of the patients who didn't delay, or I'm sorry, half the patients who delayed didn't go backwards. So at the end of the day, we were able to conclude that in all likelihood for most patients, or at least about half of the patients, getting it done at a cadence is important for the overall outcome. But for the other half of the patients, it doesn't seem to make a difference. So regrettably, I don't think that that's one that we'll be able to parse in this new study. But that's an interesting question as well, right? Is there something there that could be pulled out of our existing data? Maybe. I'll have to think about that. Dr. Centeno, have you looked at combo EDS and post-trauma patients who have had both in the data? Yeah, Josh, the problem with trauma and the EDS subset is that it's usually relatively minor trauma. For example, in our normal ligament patients, it's usually something substantial. In fact, I was just looking at that this morning. In our EDS patients is usually something that we would consider fairly minor. So, for instance, one of the EDS patients this morning flared up with a very aggressive Rolfing type massage. Now, or at least that's what she said caused her symptoms. Now that's possible in an EDS patient, but really not possible in a normal ligament person, for example. Hallie, how do you respond to patients who comment on improvements felt at 5 to 9 month mark? Are those 100% down to other therapies like PT, posture curve correction, etc.? Not quite sure what you mean there. Basically, we'll look at outcome at various time points, 3 months, 6 months, 12 months. For some patients, 3 months is good. For other patients, they're still in a flare-up mode. That's probably the minority, maybe 10, 20%, but that's a confounder. When we look at 6 months, that's probably the purest outcome that we have, because almost everyone is no longer flared up, and we're seeing what the outcome is going to likely settle in at. And then, as I've said before, the purpose of the PICL procedures is to establish a base, meaning no one getting this procedure could do exercise and would respond before. In fact, almost universally, when they tried that, they would get substantially worse. So they couldn't really get better with just those sorts of conservative things, whether it was PT, postural work, exercise, or AO chiropractic. After the procedure, they can do that, but that's then a procedural effect if they could do it, meaning everyone's getting prescribed rehab afterwards. So it's kind of a red herring question, right? At the end of the day, if no one in the data set could do those things before, and if afterwards they're able to do them, then that's a procedural effect all day long and twice on Sunday. Lisa, how long after stem cell treatment can a standard x-ray be taken? I don't want to damage the injection sites. Not a problem at all. Lisa, there really isn't a time frame. The x-rays aren't going to damage the cells, etc. Only thing that would be concerning is if you were going for some sort of imaging study, for example, that puts you in a situation where you had to really stress out the neck, then that could be a potential issue, but the x-rays themselves, not a problem. Jamie, I need to fill my data more diligently. I reached that 5-year mark. Just here to say thank you so much. I don't know where I'd be without your clinic. Well, thank you, Jamie. Get that data questionnaire into us, but thank you for saying that. Marcia McDaniel, does the presence of MCAS diagnosis affect the outcome? Yeah, that's a good one. That's one of the reasons why I was going through this morning and going through the questionnaires and adding that into the unstructured data, because I wanted to test that. Regrettably, this morning I didn't get through all 60-some patients on that list. So that's a project for probably this afternoon or tomorrow, the next day, or sometime this week, is to update that kind of information on there because that information is on the questionnaire, and that's a good one to run. My sense is it probably doesn't make a difference based on what I've seen, but it is in the process of being looked at. Stephanie, trying to word this correctly, do you feel there's any difference in outcomes for PICL depending on how long a patient has been symptomatic of CCI when they have the procedure? For example, someone like symptoms for a few months. Yeah, Stephanie, that's one I talk about a lot. I have noticed this one because it's sort of a dramatic effect, that if we get someone within the first 12 to 18 months of a traumatic injury in particular, or even the abrupt start of symptoms, then that person usually is only, or is more likely to be a one and done type patient, meaning a single procedure and that's all we do, or need fewer procedures than someone who has had the problem for years and years. So that is something that I can tell you that I have observed, because the signal is so large, meaning the effects seem to be so substantial that it jumps out. So I don't need statistical analysis to tell me that one. Julie, how soon after PICL would be safe recommended to have flexion extension upright MRI? Yeah, Julie, I think you'd want to give it at least 3 or 4 months for everything to firm up, and then by all means get a flexion extension upright MRI. Casey, what's the difference between platelet lysate and leukocyte poor PRP? Yeah, they're pretty different. So PRP is platelet-rich plasma. So you have whole platelets, and those whole platelets degranulate growth factors and exosomes over about the first week. So consider it a little bit like a slow release pill if you're talking about growth factors, for example. When it comes to platelet lysate is where we take platelet-rich plasma and we break open the platelets, or we lyse them to get the growth factors out. So they're immediately available. And consider that like an immediate release pill. Now, functionally, there's a difference. Platelet-rich plasma is a little bit more pro-inflammatory, and platelet lysate tends to be anti-inflammatory out of the gate. So you can use leukocyte poor, meaning amber PRP, around nerves, like in a carpal tunnel injection, for example. And it will cause some amount of flare-up before the patient gets better. If I were to do that with platelet lysate, it would be anti-inflammatory. So it would be much better results out of the gate. Now, whether or not there's a long-term difference in results between the two around nerves, I don't think anyone has studied yet, but it's an interesting question. Christian, can CCI cause instability in other joints? Best thing to say there, Christian, is that if you look at CCI or upper cervical issues, they can certainly cause, for example, the low back stabilizing muscles to go offline. And then that can cause instability in the low back from a muscular standpoint. And then that could cause problems, for example, in the low back. Or we might see position sense or proprioceptive issues impact the way you're using one arm or one leg. And that might lead to instability in those joints. So that's how those two things can be related. It's been advanced by Harry Winston. Is physical therapy for CCI recommended, or should it be avoided if our ultimate goal is the PICL procedure? Yeah, I would always try conservative care first. And if that fails, then that's when you would go and consider injection therapy, and you'd have to then get your CCI typed. And then that would map to a treatment that could include the PICL procedure. So having said that, if you try active physical therapy and you flare up big time, then that's an important piece of information for us in that whole diagnostic treatment discussion, right? Is this CCI? Well, that's one of the ways that CCI patients respond. And then we'd look at other things in order to make that diagnosis. Casey, what's the difference between, I think I got that one already. Maybe accept CSC fellowship. Let's see, Josh, what were you asking up here? Josh, not sure what that one refers back to. Marcia, thinking of the Nicholson paper, have you found a lower limit of CXA that correlates with the success of the outcomes? Yeah, Marcia, that one is already in the larger registry data set. I had one of our fellows synchronize reading techniques with me. That CXA data is already in there, and that's already a part of the existing analysis of the registry data set. I think what you're talking about in the Nicholson paper is, at the end of the day, online, what I call the social media diagnosis. A lot of patients believe, for example, that a CXA of 135 is pathologic. It's not, based on the Nicholson paper. Or other patients believe that a CXA of 130 is pathologic. Again, it's not, based on the Nicholson paper. So what Nicholson really does there is it kind of moves the normal CXA range down a bit to about 125, 126, if I recall. And then so anything under 126, we should start to get really concerned. Now, what Nicholson doesn't do is it doesn't really try to put people into symptomatic and asymptomatic groups based on those numbers. And what we'll do is to see if CXA has any impact on outcome from the PICL procedure. Raj, do you sell CCI supplements on your website? We have a stem cell support formula that we provide at the clinic, and that's a supplement that was designed in the lab to be healthy for stem cells. But I don't think we sell it on our website at this point. Liam, it seems 2B is pretty common. Is that the reason? Is there a reason that might be the sort of trauma, or is that ligament just more likely to get damaged? Yeah, Liam, I think that there's two reasons there. One is I do think it's probably more common, all things being equal. The other is that we tend to see it it's more likely to be in our data sets because it's a common one that we can find on DMX. So, for example, if all we ever used was flexion extension MRI, upright MRI, we wouldn't see any 2Bs because you can't make that diagnosis using that. So I think it's true that it's probably more common based on what I've seen. But you have to realize that our data set and our methods tend to bias for it a bit. DMC, how common is tongue symptoms in CCI, numbness, tingling, etc., specifically with type 1A and 1C? Tongue symptoms are common. If you go to my YouTube channel and you pull up the information on the 7 nerves that really make CCI patients miserable, I think is the name of that. And I go through each and every one of those nerves in YouTube Shorts. You can see which nerves actually impact the tongue. That's usually cranial nerve 12, but there's also cranial nerve 9 where you've got sensation in the back of the tongue, etc. Natick, what stretches would you recommend for pelvis and ribs if they're worsening CCI or stop CCI from getting better? That would require a diagnosis of what's wrong with your pelvis and ribs. And I don't know that obviously on a social media thing like this. So I'd have to get to a diagnosis to answer that question. There is exercise just like anything else, right? If you do the right exercises, you can get better. If you do the wrong exercises for the diagnosis, it won't get better or could make it worse. So I don't know the diagnosis. Just having pain in those areas isn't a diagnosis. There are specific things that cause those issues. Matt, have you been surprised by your findings from the recent data analysis? Making see all of this. Another provider gives this data. That's all hit and hope. Thank you. Not so far, Matt. I am a little bit surprised at the consistency of the signal that hypermobility doesn't seem to make a difference, because I could have gone both ways on that one. I'm a little surprised that the CCI type so far doesn't seem to make a difference, but there's some hints there and trends, so we'll have to see if that plays out in the larger data set. And so those are really the things that surprised me just a little bit. You know, what I try to do in my clinical practice is to say, okay, what can I notice as a human about what's got really big signal, right? Meaning the changes are so different that you can see them from a mile away, and then understand that there's probably stuff in there that I'm not seeing or not noticing because of my own personal biases. And that's why we run this data periodically. We've run it now multiple times. Now we're at that point where I feel comfortable enough about the procedure. It's all dialed in, locked in. I feel comfortable enough about how we're recording outcomes. I feel comfortable enough that I know the right questions to ask, that it's time to get out a peer-reviewed publication. If, you know, even 3 or 4 years ago, I wouldn't have really known, you know, the procedure wasn't fully locked in yet. Even the mouthpiece wasn't fully locked in yet. The questions to ask weren't as mature as I can get them now. So that's why we're pursuing this. But thank you. You're right. A lot of people doing this work aren't taking the time, aren't spending the money to do the research, and that's not good. We should push more providers doing this work to do research, because it would be interesting to see if all of that correlated from provider to provider, et cetera. Raj, do you just want to, doctor, just want to ask you, will you ever try to do EPICL procedure using prolotherapy instead of stem cells? I know stem cells are most effective. I'm curious about the cost for the patient. No, Raj, we're not going to do that. If we're going to take the additional risk of the PICL approach from the front, we're not going to do anything but put our best foot forward. Prolotherapy would be dangerous in that space because prolotherapy is a neurolytic, and you could theoretically inject around the dura or the covering of the spinal cord. So prolotherapy would be a non-starter, something that would be a really bad idea to use for a PICL. And then PRP is going to underperform bone marrow based on our experience and what we've already published in treatment of ligaments. So no, I don't foresee us doing that. Listen, you've got fake and bake providers in Europe who are playing that game, mostly because they don't really have a lot of experience with using bone marrow, so they're more comfortable with PRP. But to me, it's a dangerous thing to do. The whole fake and bake PICL is a dangerous thing to do. But if you're using a little bedside kit to make PRP, man, that's a lot of risk for the patient, right? You're having some MA, screw something on, who knows if that's a sterile process, put it in this thing, run it, manipulate it, take it out, hand it to the doctor. Again, all of our processing at our clinic is done in a CGMP clean room. Now, that's $1 million facility versus 20 or 30 grand for a cheap little PRP kit. So, I'm willing to spend that money if it adds safety at the margins. I don't think I'd ever use a kit-based system, for example, to inject these ligaments through a PICL because of the additional risk that would add. And I wouldn't inject anything that didn't put my best foot forward on trying to get that thing healed. Casian, why do academic institutions avoid regenerative medicine when they should be able to attach grant money to do so? Casian, I'm not sure that they're avoiding it. I think what I have seen through the years is academic institutions that want to have their cake and eat it too, right? The cake in this case is they want insurance reimbursement or grant money. Those are the two things that academic institutions and medical centers are very focused on. You can get grant money for doing regenerative medicine studies. And for example, Emory is doing a really nice study right now with bone marrow concentrate through Ken Mountainer, MFAT, bone marrow concentrate, stromal vascular fraction, PRP. And that's a privately funded study. It didn't come through large government granting organizations. I think in addition to that, it's probably harder to get regenerative medicine funding through large NIH or NSF sources because those tend to be more focused on keeping the grant game going than they are on really trying to fund breakthrough research. And I've been a long-term critic of the NIH funding system because it's kind of all about, how do I eke out the next bit of money from my university, not really funding what's likely going to cause a breakthrough or rewarding people who have made breakthroughs or appear to be making breakthroughs. It really rewards the pencil pushers more than it rewards breakthroughs. So that's what I think. Aliyah, Travis. Will you accept a patient with Medicaid who wants to self-pay? I don't think having Medicaid should prevent someone from being able to seek treatment. Aliyah, the biggest issue with Medicaid, and it's a big problem here in the United States, is that if the doctor doesn't take Medicaid, then you can't be seen by that doctor for anything that Medicaid covers and pay cash. That's illegal. So for example, the initial evaluation, let's say you need to be seen 3 or 4 times and I have to order an MRI or additional imaging or other blood tests or be seen in follow-up. Since Medicaid would cover those, but since I'm not on Medicaid, I can't bill you for any of those services at all. So that's what happens here. It's one of the reasons why I would say Medicaid is probably the worst of the worst when it comes to insurances because it limits patients' abilities to go outside the traditional medical care system, because any doctor who lives outside that system that wants to see you and bill for something that Medicare would normally cover can't do it. So I would say, Medicaid would be the worst U.S. insurance to have in all circumstances because of that. It really limits patients, and I hope they fix it one day, but it's kind of just a bureaucratic nightmare right now. Matt Crate, it would be fascinating to see data on healing timelines and maybe why. See the different anecdotal stories, timelines, some are better than 3 months. Yeah, that's a hard one for us, Matt, simply because, we only look at certain time frames, right? We send out a questionnaire at 3 months, at 6 months, at 12 months. So we'd have to start asking patients, when did you first notice a dramatic improvement or something like that? And regrettably, that's going to be a pretty subjective question. So that one is a lot harder, I think, for us to study. And regrettably, those are the limitations of existing research techniques. Now, just to let you know, and this could help, starting Monday, we're going to be doing an AI-generated transcript, which we've already done for a couple months, of every single patient interaction in the office, maybe to pull out unstructured data like that. So, for example, that could be part of an unstructured interview that future AIs, maybe by the time we get to AI 2026, we'll be able to easily pull out of thousands of pages of unstructured interviews on hundreds of patients. So we're already starting that, and we're already starting all sorts of things to prepare ourselves for AI data collection and analysis that current AIs might struggle with, but 2026 and 2027 AIs probably won't struggle with. So we're putting things in place now to try to pull out some of those inferences based on some of the advancements that we're going to expect to be there by next year or the year after. Kasian, would you think, since academia can attract grant money, I think I got that one already. Josh, thanks. I was asking for a friend who has EDS history of whiplash. Gotcha, Josh. Neva, does the curve correction and PT that you offer come together with the price of a PICL? Neva, we don't offer curve correction in our clinic at all. We don't offer PT like that. So if we send you, for instance, for curve correction, we're going to send you to one of the certified providers around the country. And you can actually already find those people today. If you go to idealspine.com, they're listed there. Or we might have you do online postural type physical therapy with Todd Ball. Todd will charge whatever Todd charges. Or we might send you to IPA physical therapy locally. And obviously that person is going to charge what they charge, or they're going to be on your plan or not on your plan. So no, our focus is on doing the PICL procedure, and we will refer you out for those other things. Neva, I have an upright MRI of the craniocervical junction with flexion extension, also normal supine MRI. Would that be enough? Do a telehealth. Neva, I'd have to review that. So how a telehealth is done is you submit the information you have. I personally review every single one of those to try to see if we have enough information at that point to get to a diagnosis. And if there is on the upright flexion extension, and it doesn't cost anything to do that, then we will allow you to move forward with a telemedicine visit if you get through that pre-screen. Now, let's say on the upright flexion extension MRI, you didn't have anything that looked like CCI. Then in that first free analysis, that again, I do all of those for nothing, then you might be told you need a DMX, for example. So you might want to go out and get a DMX. And what I'm trying to do there is to prevent patients from wasting time, energy, and money and getting on a telehealth where no conclusion is going to be drawn about whether or not we can help you or not. So that's really what I try to do. It takes a lot of my time, but I do it because if you're going to pay that money for a telehealth, I really want you to have something that comes out of it, not just, well, you don't have enough stuff, I can't help you, or meaning enough diagnostic information. Greg, I greatly appreciate you putting the time, energy, effort, and research aspects CCI. That says a lot about you and your business. Look forward to seeing you in October. Well, thank you, Greg. Yes, it takes a lot of time for sure. But it is important to do. And I would encourage CCI patients to put some pressure on other providers to do it, because we're never going to get CCI moved into the mainstream of every single family doctor out there looking for this, or every spine surgeon looking for it, or every neurologist looking for it, or every pain doctor looking for it, or every physical therapist looking for it, until we can get publications in the peer-reviewed literature about it. And a lot of them. So to do that, we need more providers out there doing research like this, or we are, as a community, never going to get to that spot. Elliot, can re-injured ligaments be treated again, or is there a limit in how many orthobiologic treatments a ligament can respond to? They can, Elliot. It's really more about how much damage there is to the ligament. So you can certainly get too much damage to a ligament, in which case we're not able to help that ligament. So that assessment would have to be done after each injury. Hallie, Todd Ball's posture program has people returning to isometric PT exercises 3 weeks out from PICL procedure tolerated. Do you approve this time frame? Yes, I do, Hallie. Yeah, Todd is, listen, I have to give Todd some kudos here and some credit, because a couple of years ago, I think he was working with John Schultz, and he kept beating on my door. Hey, I'd love to work with your patients as well. I'd love to work. And I kind of ignored Todd. I had a lot going on. And then about 2 years ago, I finally gave Todd the time of day, and he showed me his program, and I started sending a few people. And what really happened over that next 2 years is Todd really learned through the school of hard knocks which of our patients would flare up and which of our patients wouldn't, how to morph a PT postural program for that particular person so that it would dramatically reduce the likelihood or the risk of flaring the patient up. So he's really done a great job of morphing his program, and I have to give him a lot of credit for spending the time, energy, and effort to do it. And even just for continually pushing me, trying to get me involved, since I was seeing the most of the CCI patients. So yeah, I do agree with that approach, and I think he's done a lot of work to try to morph his program to make it as safe as he can for what is a very difficult patient population to treat in CCI patients. Elliot, how much more dangerous is cervical fusion compared to a PICL? 100 times as dangerous. Yeah, Elliot, here's the only way I can do that math, if you will. And this kind of math is never super easy to do when we're talking about relative risks of procedures. What I can say is this: if you look at an upper cervical fusion, and you look at the percentage of time someone gets something bad enough to wind up in an ICU. Excuse me. Let's start over. So if you look at the number of times someone gets something bad enough with a cervical fusion to wind up in an ICU, it's probably in maybe the 10% range for an upper cervical fusion. If you look at the percentage of times that someone gets something from the fusion that's bad enough to warrant additional surgery or substantial medical care in managing that thing or that complication, that's probably 20% of the time. So if we then compare that to PICL, we're at more than 2,000 procedures and no one's ended up in the ICU as a result of this procedure. We're at 2,000 procedures, and the number of patients that have gotten severe things that require substantial additional medical care that are clearly a result of the procedure, meaning there's a clear connection. The procedure happened, and then that thing happened, and then that resulted in substantial medical care, i.e. a surgery. It's, near as I can tell, zero or pretty close to zero. So, is that 100 times safer, 1,000 times safer? I don't know, but I can tell you it is dramatically safer than a cervical fusion if you just look at the published data on complications for cervical fusions in general and upper cervical fusions in particular, which are even higher risk. Lindsay, have you ever studied patients with EDS who have ligaments damaged from CIPRA? Would PICL be able to help them? Lindsay, I would say that the minority of our patients who are getting a PICL procedure have had a floxin, like ciprofloxacin induced injury. Now, again, we got to be careful with this because we have data that floxins cause tendons, and even that's argued back and forth in the medical community. So I would say there's strong enough data to say that floxins or ciprofloxacin or those sorts of quinolone drugs can produce tendinopathy. What we don't really have data on, I've looked at this multiple times now, is that quinolones or floxins produce ligament injury. Those two things are lumped together by patients, tendons and ligaments, but they're different things. So I would say we don't have good enough data to draw that conclusion at this point. I would say we do have for tendinopathy, but even that one's going to get an argument. Will probably be 50-50 on the traditional doctors who state that relationship is strong. We don't have that same kind of data for ligaments. Marcia, is there an anticipated instability in lumbar spine after TC surgery that can be helped with orthobiologics? Marcia, tethered cord, again, occult tethered cord, because we're not talking about tethered cord. Very important to make that distinction, right? There's a tethered cord, which is where we can see the conus medullaris, or the bottom of the spinal cord, pulled down. There's an occult tethered cord where there's a theory that there's too much tension, but there's no movement of the bottom of the spinal cord downwards. So if we're talking about OTC, which is probably what we're talking about, given my experience with the CCI community, does that cause instability in the lumbar spine? Not that I've seen. I would say, however, as I've told this community many times, and this community tends to freak out about all of this a little bit too much, in my opinion, that I don't recommend OTC surgery for the vast majority of patients who are getting it, because many of them are getting it for things like back pain, urinary issues, etc., that are caused by back problems that have gone undiagnosed and not caused by occult tethered cord. So I don't want to get too far into that rabbit hole, but at the end of the day, I haven't seen occult tethered cord release or a tethered cord release cause lumbar instability. Lynn can undergo Blair upper cervical chiropractic care after being confirmed it's safe enough for me. That's a decision for your doctor and the Blair chiropractor. Jay, I have a ganglion cyst in each foot from prolonged lumbar instability and severe ankle pain with crepitus and severe pain with something rotation and prolonged walking. Once I treat the lumbar instability, will the ganglion cyst go away? Yeah, Jay, that would take a hands-on physical exam to answer that question. Jimmy, I'm dying from failed CCI surgery, extreme vibratory sensations and paresthesia, choking, entire upper body is locked up, extreme muscle spasticity. Don't think there's a questionnaire. I think that's a comment. Yeah, Jimmy, as I've talked about many, many times, as we go from things like PICL into CCI surgery, the risks go up of really bad things happening. So I'm sorry, very sorry to hear that. Debayan, is it necessary to do AO nuca adjustments before PICL? No, it's not. If you have an existing relationship with an upper cervical chiropractor and that really seems to help you, then I would recommend that you keep that relationship and keep going. If you have never tried it before, there isn't a requirement that you do it. Lynn, at which level of cervical instability involvement produced TMJ and jaw misalignment? If you had to venture a guess, all things being equal, it would be the upper cervical spine more involved than the mid or lower. KCN, and I'm going to start winding this up because the questions keep coming, and I'm at an hour and 5 here. But let me take a few more here. I'm going to start to sort of filter the questions and look for super interesting ones. KCN, of other CCI typing that exist on the internet, what do you find incomplete or wrong that your typing resolves? I don't think there is other CCI typing on the internet. I think CCI typing on the internet right now is pretty coarse, right? Not granular. So we have, for instance, the difference between CCI and AAI, pretty coarse. AAI involves C1, C2, and presumably CCI involves everything else. We have, for instance, vertical instability, but that then excludes all the other kinds of instability. So probably the biggest issue my typing system focuses on is that there are specific subtypes of CCI, and we've got to get granular if we're going to figure out what to do to try to help that person. Now, having said that, in defense of the surgeons that use the other types, you may not need to be as granular, right? If you're just going to fuse 0 to 3, what do you care if it's 0, 1 or 1, 2 or 2, 3? You're just going to fuse it all anyway. So that probably is what drove the differences there. Okay, let's see. I'm only going to pick some interesting ones here. I don't have a GRT flipper. Great flipper, maybe. If mostly left facet joint capsule C1, C2 tear, there's no imaging that makes that diagnosis, so I'm not quite sure how that was determined. Would it be okay to start with a C1C posterior facet joint injection with Dr. Sebastian Klisowitz in Florida and then go to you for PICL for more help? Yeah, I can't recommend that physician to do C1, C2 injections at all. So that's sort of the first thing, meaning that we don't recommend anyone out of Colorado, number one, to do C1, C2 injections. Number two is to do a C1, C2 injection. You would have to have extensive experience, extensive interventional spine training with fluoroscopy. You'd have to have a fluoroscope, use contrasts and digital subtraction angiography to keep it safe. So that provider in particular, in my opinion, would not pass all of those tests. And then in general, the concept of a facet joint capsule tear, there's no way to make that diagnosis as causing your instability. So again, as I've talked about before, the first thing is get movement-based imaging. The second thing is to get typed. The third thing is based on that type, I could then in general answer what type of treatment might be needed. So for example, if it was a type 3A, even simple prolotherapy, which I'm sure that provider could handle, would be a great fit. If it's a type 2B, then posterior injections not going to work, that kind of thing. I don't know what that one's all about. Jay, do many patients see central peripheral nervous system with PICL, or if there's CCI and lumbar instability in the mix, could be compromising nervous system, even more causing widespread muscle sensory issues, joint pain, systemic nerve irritation, symptoms like tingling, crawling. A lot to unpack there, Jay, but I think maybe the way to answer this question is to say that a lot of our patients have CCI and low back issues. If they're connected or even separate, we try to treat them at the same time, or at least start treatment of, let's say, the low back while we're doing the PICL, and maybe find someone or that patient, a local provider, who can see them for further low back injection. So it's very common for us to treat both. Let's see. Liam, what's the most challenging thing you find when doing the PICL? I think the most challenging thing and exciting through the years has been, how do you dial in a procedure that no one else on earth has ever done before? Yeah, we got some old German textbooks that talk about just sticking a needle back there and injecting some steroids if you had certain kinds of patients. but that's not the same thing as a PICL. So how do you dial in a procedure when the anatomy isn't really well known, when no one's actually even has a textbook or a paper you can look at that says this is how you do it? No one's ever tried to inject contrast in these ligaments to see how they flow. No one knows even how they're kind of connected in real people. No one knows what the pitfalls are, like bursa, I think I've talked about before. So that's really been the most exciting thing. And the most exciting thing in the last couple of years, the two most exciting things, have been the EPICL variant, which is nothing like the original PICL procedure. So that's one of the reasons why I laugh a little bit, hearing that patients are going to some crazy place in Europe to get a fake and bake PICL, because the procedure that's being done bears no resemblance to the EPICL that's being done today. So that was a super exciting one, realizing that there was a way to do the procedure that was completely different, that would allow us to dramatically improve and confirm that 100% of the time we were in the right ligament. That was an amazing advancement. And I couldn't get there until I got to about probably 1,500 procedures. Maybe not 1,500 that I did. I would say I probably did around 1,100 of those, 1,200 of those. And it took that many to say, aha, there's a much better way to do this thing. And the other big one that's been exciting most recently has been that 5th generation mouthpiece. Damn, that thing is good. And that took years to design. Literally years of thinking about it, years of looking up data from published studies on the size of various parts and pieces in the mouth. And so those are probably the two most exciting things that were also challenging, right? We used 4 different mouthpieces before that. The 4th generation one was pretty good, but it failed on the edge case uses. So that's a great example. The 1st generation one was literally just use a tongue depressor. The 2nd generation was use something that's off the shelf that we can buy from a surgical supply house that's used for another purpose. The 3rd generation one was, kind of a 3D printed thing, but it was not all it's cracked up to be. It had some severe limitations. By the 4th generation, it got pretty good. And by the 5th generation, it's dialed in. So those are the exciting things for me. Okay, guys, well, I got lots of back and forth happening here. But anyway, long story short is I want to thank everyone for being here today. Again, I've tried to share some data so that you can all see that we are working on this paper. I'm not trying to rush it. I'm not because I want to do this thoughtfully. I want to do this where I've got a smaller data set I can test, and I can start to answer questions in the larger data set that will produce meaningful insights for the CCI community. So for example, if it turns out that you've got a 1A and you're less likely to respond, that's something I want to know. If it turns out that if you have MCAS, this is less likely to work, that's something I want to know. So all of these things and the time we're taking with this and expanding it out to more patients allows us to start answering those questions. Because one of the problems with data is once you start slicing it, dicing it into 5 and 6 and 7 groups, you have to have really large numbers to make sure that those things are statistically significant between those groups. So thank you for your patience and all of that. And thank you for your time this Sunday. I will be here next week as well with another presentation, and have a great week. Thank you.